But the primary endpoint of the study was the percent of patients who would essentially get through 2 cycles and will start cycle 3. And it was powered for superiority. So we thought the dose escalation strategy, and it's a strategy and dose escalation, going from 80 milligram on week 1 to 120 milligram on week 2 to 160 milligrams on week 3, and then a week off. And whatever dose the patient ends up being on in the first cycle is the dose they get into the second cycle. Then that was the strategy. So you really have to do the weekly escalation if the patient, of course, can't tolerate it. And then the 160 was Arm B. And the primary endpoint of the study was met. The primary endpoint was met. In fact, it was about 20% better for Arm A versus Arm B. So not only was met, and it was higher than expected, and the p-value was quite significant. One of the surprising findings of the study was survival benefit on Arm A, the dose escalation arm versus the standard arm. So going from 80 to 120 to 160 in the first cycle seems to confer a survival advantage, although statistically it was not significant, but the deltas were quite separated, and it was 9 months versus close to 6 months. Now here's the interesting part is Arm B, which is the 160, looks exactly like you would expect it from the correct trial. So our control looked exactly similar, I should say similar because there's no exactitude in comparing 2 different studies, but very similar to what you would have expected to from the correct trial. So our control was a good control to have. A was really on top, and it went all the way beyond the year, continuously on top. So it was quite a remarkable improvement in survival. The progression-free survival curve was dropping less fast on Arm A versus Arm B. And most importantly, the toxicity profile was improved with the dose escalation strategy versus the 160, so 80 to 120 to 160 in the first cycle.